we're going to talk about the IVF process. IVF process consists of 4 basic steps. One being the controlled ovarian stimulation. Second, egg retrieval from the female partner. Third is the fertilization in the lab. And fourth is putting them back, which is called the embryo transfer. So we talk about controlled ovarian hyperstimulation. Controlled ovarian hyperstimulation means that we want to produce more eggs. Usually in the normal menstrual cycle of a female, only one egg is formed per cycle, that is in 1 month. By means of artificial injections, which is called gonadotropins, we would like more eggs to be produced in either of the ovaries. These injections are administered for around 10 to 12 days in the initial part of the cycle. Before giving the injections, we assess the ovarian reserve of a patient to decide on the dose and the type of injection. The assessment of ovarian reserve is done by means of ultrasound or by means of blood test or combination of both. Usually done on the start, which is the first or the second day of the periods. Based on the reports of the hormonal profile and the ultrasound, we decide on the type and the dose of injection that is to be given. We individualize the dose to an extent so that we do not form too many or too less number of eggs. The injections are started from the second day in the antagonist protocol that we commonly follow. The injections initially are given for say 4 or 5 days. We ask the patient to come again after 4 to 5 days of injections for an ultrasound. Based on the ultrasound, after seeing the growth of the eggs that has happened, or we couple them with the hormonal profile or blood test to see how the growth is. We add on a second injection, which is called the antagonist, to prevent the rupture of the eggs. Now, from henceforth, 2 injections are continued to be administered for the remaining days of the cycle. Once we add on an antagonist, probably the patient is asked to come for the ultrasound on alternate day basis, or after every 2-3 days. We monitor the growth of the follicles, and once the desired size of the follicle, which is around 17 to 18 mm, is achieved, we give the final injection, which is called the trigger. The trigger is timed in a manner so as to fix the time of the egg retrieval. The trigger is usually given in the evening or the night hours, and we schedule the pickup or the egg retrieval after 35 to 36 hours of this final injection. These gonadotropin injections are produced from recombinant forms, and they are very pure, so do not have any side effects per se. These injections are administered in the pen form, just like an insulin syringe, and are self-administrable, or probably the partner can administer them. So for this particular injections, probably the inconvenience of going to the hospitals or the IVF center to get them administered is least once the patient learns how to administer them. Same is true for the antagonist injection that can also be administered under the skin, which is called a subcutaneous injection, and can be done by the patient herself. These injections are usually given for a total of 10 to 12 days. And if the OPD visits can be scheduled in the evening hours, probably this period doesn't require any form of rest or off from work. Thereafter, we move to the second step, which is the egg retrieval. What is egg retrieval or ovum pickup or oocyte pickup? This is the process wherein whatever eggs, whatever follicles we have developed during the phase of ovarian stimulation in an IVF, we would like to retrieve them, give them to the embryologist for the process of fertilization with the partner sperm. This process is carried out under anesthesia. A short general anesthesia is given to the patient on the day of the egg retrieval. So for this procedure, the patient is advised to come nil per ovum, that is, she is not supposed to have anything from the night before the egg retrieval is planned. Only the medications that are need to be taken in the morning, say like the thyroid medication or the blood pressure medication, needs to be taken before the egg retrieval procedure. The patient is laid down in a position, in the lithotomy position, which is very similar to performing the transvaginal or internal ultrasound. This procedure is performed by means of a needle that is mounted over the ultrasound probe, which is introduced into the vagina, which is the birth canal of the female, and the vaginal wall is punctured to reach the ovary. One by one, the follicles are pierced and the eggs are aspirated with the fluid that is there in the follicle, and they are collected in the tube. The tubes are simultaneously passed on to the embryology lab, which is placed just next to the operation theatre wherein the procedure is carried out. The embryologist would screen the fluid for the number of eggs that are there. The procedure usually takes around 5 to 10 minutes depending upon the number of follicles that are there. The patient is immediately revived of the anesthesia. The patient may experience mild amount of cramping in the lower abdomen post-procedure. However, there is not much amount of discomfort. The bleeding could be just to minimalize spotting, which usually subsides by the evening of the procedure. The patient needs to be under observation for 3 to 4 hours after the procedure because it is done under anesthesia. Apart from that, the patient is allowed orally after 3 to 4 hours and can go home the very same day. She needs to take an off from work because these procedures are usually scheduled in the morning hours, but she can join back duties the very same evening if she wants to, or probably the very next day, as individual case may be. Post procedure, the prescription is given to the patient consisting of antibiotics, the painkiller on SOS basis, and progesterone support that needs to be started from the very day of the egg retrieval and is continued till the day of pregnancy test. The patient is then advised to contact the lab, or the lab would contact the patients to give the details regarding the number of eggs retrieved and how they are behaving in the incubator on daily basis, so as to schedule the embryo transfer accordingly. The third step in IVF is fertilization. Once after the egg retrieval, the eggs are passed on to the lab. Then on the very same day, the husband is required to give the semen sample. His semen sample is washed to concentrate the maximum number of motile sperm. This concentrate is then allowed to fertilize with individual eggs in the dishes that are kept into the incubator. However, in specialized cases wherein the sperm number is low, probably a procedure called ICSI, wherein egg is held in one holding pipette and the sperms are injected one-on-one basis under the microscope, needs to be performed if need be. In conventional IVF procedure, the egg is placed with the washed semen sample and incubated. This is marked as day 0. Thereafter, on the subsequent days, we like to see how the fertilization has happened and whether or not the fertilized embryos are growing well. So for this purpose, we try to stage and grade the embryos on daily basis. Staging would mean that on day 1, the eggs and the sperms would have fertilized to form the zygote, which is the first cell of any baby. Day 2, they should have turned to 4-cell stage. Day 3, multiplied and turned to 8-cell stage, and henceforth. With this, also we would like to grade the embryos on international basis. This job is done by the embryologist, and we are aiming to get at least 2 to 3 good grade embryos so as to plan the embryo transfer and decide whether to freeze the excess embryos if any. Usually on the day 3, if we have surplus good number of embryos, we like to culture them to the blastocyst stage. This is called blastocyst culture because herein we would change the media and culture them to the day 5 or day 6, which is the blastocyst stage. The blastocyst has a higher chances of getting implanted and giving good pregnancy outcome. The surplus embryos are cryopreserved and frozen for further embryo transfers in case this leads to a failure or in case the patient comes for a second baby years later. Embryo transfer procedure is performed either on the day 2, day 3, day 5, depending upon the stage and the grade of the embryos that we have with us for an individual patient. The embryo transfer is performed without anesthesia under ultrasound guidance. On this very day, since this is without anesthesia, the patient has a light breakfast in the morning, reaches the lab on the required time, and the embryos are shown to the patient and counseled about the grading and the number of embryos that we plan to transfer to an individual patient. This is performed by means of a catheter. The embryologist would load the embryos in a catheter and Under the ultrasound guidance, this ultrasound is performed over the abdomen, that is transabdominally. We like to place the embryos at the point of maximal implantation into the uterus, that is the womb. Once the embryo transfer is performed, the patient can get up in half an hour itself. There is no added advantage of extra rest on that very day or in the subsequent days as conventionally thought. In fact, patients who are working can join back their duties from the very next day. However, there are certain set of medications which is called a luteal phase support medication that we prescribe to the patients after the embryo transfer procedure. The luteal phase medications are individualized. It consists mainly of progesterone support that was started from the egg retrieval and continued till the day of pregnancy test, which is 14 days, roughly 14 days from the day of embryo transfer. And then, depending upon individual cases, if and required, other medications like aspirin or heparin can be added.